Good evening and greetings. Thank you for joining us for an impactful, important, and timely dialogue about breast health and genetic testing in recognition of Breast Cancer Awareness Month. We feel that breast cancer remains an important component for Black women as we serve as leaders in our families and caretakers for our loved ones. Women must maintain their health to continue to empower our families. We are also here this evening to celebrate breast cancer survivors too. My name is Jessica Hill, and I have the privilege of serving as the president of the Mu Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated. On behalf of our more than 700 members, thank you for logging in and welcome.
Now it's time for the introduction of our moderator, Ashley Dedman. Ashley is a BRCA2 positive breast cancer previvor and was a teen caregiver of two parents with cancer. She volunteers on various health equity initiatives with the Vassar's Young Leadership Council and the Black and BRCA Initiative. She earned a Master of Public Health from Florida A&M University and pursuing her doctoral degree with a focus on breast cancer disparities. Ashley is a new initiate of Alpha Kappa Alpha Sorority Incorporated via the Mu Kappa Omega chapter. Now I'd like to turn it over to member Ashley.
Thank you, Devana. Good evening, everyone. My name is Ashley Dedman. I am a BRCA2 mutation carrier, a trained scientific research advocate and consultant, and blessed to serve on a myriad of cancer and genetic work groups, committees, and boards on the state, local, national, and global levels. On behalf of the Vassar Center, we are so pleased to be partnering with the Mu Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated and Julia F. Thompson Incorporated on this program to support the power of breast cancer screening and genetic testing in the Black community. The opinions and experiences shared tonight are the panelists' own and do not represent those of the Vassar Center or Penn Medicine. You should consult with your healthcare team should you have any questions about the specifics of your health and medical plan. Thank you to our panelists for joining us this evening for this very important discussion. I'd like to get started this evening by introducing our panelists and thanking them generously for offering their time to this event. First, we have Lindsay Livingston. She is a proud 2-year, 7-month breast cancer survivor and BRCA1 gene mutation carrier. She celebrates her cancer-free status as the founder of Survive Her, a breast cancer awareness and wellness nonprofit. She recently penned an article about survivorship in the September-October issue of Essence magazine. Lindsay is a member of the Mu Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated. Next, we have Candace Robinson. Candace is a proud 3-year breast cancer survivor and certified Tiger Lily Foundation Angel breast cancer advocate. Her breast cancer experience inspires her to create Survivor Swag, a lifestyle clothing brand that promotes a healthy lifestyle for survivors. Candace is a member of the Mu Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated. Welcome, Candace. Next, we have Dr. Leisha Elmore. She is a breast surgeon who is dedicated to mitigating disparities in breast cancer outcomes for underserved populations and patients from diverse backgrounds. In addition to her position at Penn Medicine, Dr. Elmore is the chief of breast surgery at the Philadelphia VA Medical Center. Welcome, Dr. Elmore. And finally, we have Tiffany Carter. Tiffany is a board-certified genetic counselor who manages the cancer genetics high-risk cancer assessment programs in the Department of Medical Oncology and Breast Surgery at Houston Methodist Sugar Land and Houston Methodist West in Houston, Texas. She is a member of Alpha Kappa Alpha Sorority Incorporated. Thank you all for agreeing to share your knowledge and expertise with us this evening. Now let's get started. I'm going to pass my first question to Dr. Elmore. As a breast surgeon, how often do you see Black women being diagnosed at later stages in their treatment and coming to you for surgical options? And the second part of this question is, out of all the Black women you provide treatment to, how many are getting regular scheduled mammograms? Dr. Elmore, the floor is yours.
Yeah, thank you, Ashley. So I think it's important to first briefly just discuss the landscape of breast cancer in Black women. So we know that for all comers, Black women have similar rates of breast cancer diagnoses. That's what we call the incidence rate. Despite similar overall incidence of breast cancer, there are some really striking differences. So Black women are more likely to be diagnosed at a younger age, on average 4 to 5 years younger than white women. Furthermore, Black women have the highest breast cancer death, and that mortality rate is 40% higher than white women in recent years. And in fact, as of this year, breast cancer is now the leading cause of cancer death in Black women, surpassing lung cancer. So in terms of what's driving that difference, we know that Black women are more likely to be diagnosed with a more advanced stage disease or metastatic disease, which means disease that's spread outside of the breast and lymph nodes to other parts of the body. And we know that that's more likely than any other racial or ethnic group. And so furthermore, Black women are also more likely to be diagnosed with a more aggressive subtype of breast cancer, what we know as triple negative breast cancer, rather than any other racial and ethnic group. And so while these disparities in outcomes they're really difficult to talk about and difficult for me to treat and see every day, there are things we can do to improve our chances of early detection. So what's really critical is all women have a risk assessment by qualified medical providers, like a primary care provider, OBGYN, or a breast specialist by the age of 25 ideally, and no later than 30. We know if you're at average risk of starting screening, that's recommended at age 40 with annual mammogram. If you're at higher risk, then you may need to start an earlier age. So this risk assessment is truly critical. And so addressing the question of, well, do most women receive annual mammogram? We know that annual mammogram has really dropped off because of COVID. A lot of women are behind. That's not something to be ashamed about. It's just time to get back on track now. And so many women don't do it due to concerns of cost or lack of insurance, which can be overcome with programs to cover the cost of screening. I mean, if you're worried about that, reach out to me directly. There are organizations in every city, and I'm happy to help link you to them. Another thing is fear and anxiety are a big driver for women. I think it's important for us to realize that early detection saves lives. Leading with fear over faith can really be the difference in detecting a cancer when it's treatable rather than a more advanced stage. And so, it's really important for us to get that risk assessment, get annual mammograms. Back to you, Ashley.
Thank you, Dr. Elmore. And I'm actually going to pivot right back to you because I believe this is so important. We have an audience here, but can you help us first, before we go any further, define disparities? What are disparities? We know that there's disparities not only in breast cancer diagnosis, but research also shows that there's disparities in genetic testing. So before I pass it to Tiffany, can you really help us level set as to what are disparities? We hear this word, so as we begin to go through this conversation, help us to level set on what disparities are.
Yeah, Ashley, that's a great question. So disparities are systematic differences in outcomes between different populations of women. And so, it can go even a step further to what we call inequity. And so when we talk about inequity, that basically means disparities or systematic differences that are driven basically by issues with our system, both at the population level and the systems level. And so it's really those systematic differences in outcomes.
Thank you, thank you, thank you. So Tiffany, I'm going to pass it to you. Dr. Elmore just talked about disparities. We know that there's disparities not only in the outcomes of Black women, but also in genetic testing and counseling. To provide some general background for those who are joining in this event, could you please give a brief overview of BRCA? I know I'm a BRCA2 gene mutation carrier. Lindsay is a BRCA1 gene mutation carrier. What are those differences? Why do we need to get tested? How do we get tested? And what does that testing process look like?
Yes, thank you, Ashley. So before I start talking about genes, I'd like to give just a little bit of background of what genes are. So genes, we all have genes. We get them from our parents. We get half from mother, half from father. And they're basically instructions on how to put living things together. And so the role of genes in our body is actually, when we talk about cancer related, it's to keep us from getting cancer. So genes like BRCA1 and 2, they actually keep our cells healthy in a way that what happens with cancer is that those cells start to grow out of control. And so our cancer genes are supposed to repair any damage that occurs to our cells. And if they can do that in a timely manner, they can actually keep individuals from getting cancer. But we all have these genes, BRCA1 and 2, and other genes. The difference is if there is a change in the gene that will not allow them to actually repair that cell damage that can occur. And if that is the case, then the cells that do collect errors over time are not able to be repaired or gotten rid of out of the body. And therefore, those cancer cells start to grow and accumulate and can turn into tumors, and those tumors can potentially form cancers. And so when we think about genes related to cancer, again, we all have these genes. We get, and it's important to know the family history because sometimes the family history can guide us in determining if an individual is at higher risk or not to develop certain cancers like breast cancer. BRCA1 and 2 were the first genes that we started testing for, genetic testing for, back in the early 1990s. And we know that they still carry the highest increased risk for breast cancer. Some studies quote in the 70% range, others quote in the 80% range. But the increased risk is significant. The general population risk to get breast cancer is around 13%. And so that is a dramatic difference from someone who is that general population risk. I think it's also important to mention that even if there's not a family history, that doesn't mean that someone can't have a BRCA mutation or another gene mutation that increases the risk for certain cancers. Research has shown that even if there's not a family history, some individuals can still have mutations or changes in these genes that can put them at increased risk to get cancer.
Hey, I don't see it. It's not up. You hadn't switched
And
it.
so I think that you know the family history is important, but it's also important to be aware that even if we know that individuals who do have these gene changes may never get cancer in their lifetime, but they can still be passed down in the family. And as it relates to how do you get tested, there are doctors like Dr. Elmore, breast surgeons. Many people go through their OBGYNs to get tested. Individuals can go through their primary care providers or be referred to a genetic counselor like myself to look at the family history and see if they meet certain criteria to where insurance will pay for the testing. And the really great thing is that even if insurance doesn't pay for testing, there is affordable testing available. So it is a lot more accessible than it used to be.
Tiffany, thank you for that update and that information. I think it's so important to be able to share what that genetic testing process looks like. I know that's a term that many people hear, but they're not quite sure what that process looks like or really what to expect going in and even coming out on the other side of that. I know I was very fortunate to go through pre and post genetic counseling, which really helped me to know what the process was going to look like. And then post genetic counseling, which really helped me to understand my next steps in risk management. So thank you for sharing that process. I'm going to pass it back to Dr. Elmore. Dr. Elmore, we're going to talk about family history. I come from a family of 3 generations of women who've been impacted by breast cancer on my maternal or my mother's side. Great grandmother, grandmother, and mother all impacted by breast cancer and lost their lives to breast cancer. And I had a father who my father is a prostate cancer survivor. And so knowing my family history and scared about my own risk and wondering if I was going to be next, I took that family history to my OBGYN to be able to know what I needed to do preemptively to be able to protect my health. So my question to you is, do you find that patients often share a family history that indicates a higher risk of carrying a gene mutation? And do you find that patients share family history in general? Can you please elaborate a little bit more on that?
Yeah, and thanks for sharing that about your family, Ashley, because that is a presentation I often see. So people with multiple family members with, breast, ovarian or prostate cancer. And so we do know that a strong family history increases an individual's likelihood to carry a genetic mutation. But realistically, even in the absence of a genetic mutation, a strong family history may also change my recommendations for how you're screened with an earlier age of onset and access to supplemental imaging like MRI. And so, many of the patients I treat have a strong family history, which includes, like I mentioned, breast, ovarian, prostate, or pancreatic cancer. And it's often present in many family members and clusters on one side of the family or other, so mom or dad's side. But in many instances, women are not aware of their family history until they present with a diagnosis of breast cancer. So once this diagnosis occurs, they come in, they say, oh, I talked to family members and I heard there are multiple first-degree relatives, so moms, dads, sisters, brothers, second-degree relatives like grandparents, aunts, or uncles, or third-degree relatives like cousins with a history of cancer. And so I think this really highlights the importance of being our own health advocates and sharing this knowledge with our family, discussing our health with our families, because knowledge is power and can ultimately save multiple generations of lives. So for those of you listening, if you don't know your family history, I would urge you reach out to a family member, try to understand that, because if you have multiple family members with breast, ovarian, prostate, pancreatic cancer, those should set off alarm bells, and you should talk to your primary care provider, your OBGYN, see a breast specialist, request genetic counseling to talk about your risk.
Dr. Elmore, I'm going to come right back to you really quickly. So you talked about the multiple cancers. Can you also talk about, there's multiple rare and young. So can you go through that criteria a little bit more deeper in addition to multiple? But what are rare cancers? What are young cancers? What is that considered?
Yeah, so we consider early onset breast cancer basically anyone under the age of 45. But when it comes to genetic counseling, if you have family members with any of the cancers I mentioned diagnosed under the age of 50 that are, and mom, dad, sister, brother, grandparents, aunts, uncles, then you should strongly consider seeing a provider about genetic testing, okay? Especially if you have more than one. If there is a male in your family diagnosed with breast cancer, that's another big one. If there's someone in your family that's got ovarian cancer, especially at a younger age, that should prompt you to consider, testing. And so ideally we recommend testing what we call the index or affected family member, because, if you're negative, that doesn't necessarily mean there isn't a mutation in the family. So it's most important to test the individual that's been affected, because that provides the most detailed information. But if that individual can't be tested, then it's important for you to consider meeting with a genetic counselor for testing yourself.
Thank you, Dr. Elmore. Tiffany, do you find that your patients in the Black community are reluctant to genetic testing? And if so, why? And what do you say, or what would you say to encourage those individuals who are high risk for familiar cancers to get genetic testing?
Ashley, I think that some of my patients are reluctant about getting genetic testing. I think one of the biggest factors is fear of finding out that they do have a mutation, and then having to disclose that information to other family members. There's a level of shame about that, I think. I think it's a level of just not sure how other people will react to it, even though it's very important information that can absolutely save lives in families. I think that a lot of times it's just a lot of uncertainty about how it may affect their potential care and their children, their brothers and sisters, and other close family members, nieces, nephews. And so it's a lot of, it's difficult psychosocially for individuals to share that information. And they also don't want others to feel sorry for them sometimes in that situation as well. And so I think it's a lot of unpacking of those emotions and those concerns. And that's what we do in genetic counseling as well, is to address some of those questions and some of those uncertainties that patients have. And so it's important to know this information because there are preventative measures that we can offer in addition to imaging, like breast MRIs for individuals who do have a BRCA mutation. We may be able to offer them medication. We may be to reduce their risk of breast cancer by about 50%. Also, we may, some individuals may consider having prophylactic surgery, which is surgery removing the breast tissue before a breast cancer occurs, and that can reduce the risk by 96% in some cases. So there are preventative measures that can be offered. And for men in the family, it's also important for men in the family, as Dr. Elmore mentioned, increased risk for prostate cancer. That risk can go up to 30 to 40%. Also, increased risk for pancreatic cancer for both men and women. That risk is about 6% lifetime. And then the risk for ovarian cancer for women can also be up to about 30 to 40% lifetime. There's also an increased risk if a woman does get breast cancer in her lifetime of about getting breast cancer a second time, up to 50 to 60% lifetime. So, there are some preventative things that we can offer, and there are some strategies that individuals, if they do know this information, can come up with their healthcare providers, that can be life-changing and life-saving, not just for them, but their family members have a 50% chance of also having that genetic mutation that they can potentially pass down to other family members.
Thank you, Tiffany. I think that's so important. It's so important to not only know our family history, but be able to share that information with our providers so that you know what your options are. And I was very fortunate to be able to explore all my options through increased surveillance over 10 years. And then deciding later to have a preventative double mastectomy to reduce my risk. And that really is going to be a transition point where we now transition to really hear from two amazing women who have been diagnosed with breast cancer and are now in thriving and surviving. And so I'm going to start with Lindsay. Lindsay, how did you find out you had breast cancer in your genetic status and family history? Can you please share your story with us?
Yes, well, good evening, and thank you, Ashley. In July 2019, during a self-breast exam in the shower, I felt a lump in my right breast, and I immediately scheduled a well woman exam. And it was during that well woman exam that I received my very first mammogram at the age of 37, a 3D mammogram, breast ultrasound, subsequent test, a biopsy confirmed that the lump that I felt in my right breast was cancerous. I was diagnosed with triple negative stage 2B breast cancer, which is the most aggressive subtype that affects Black women at a higher rate. I started my treatment plan that would include chemotherapy, lumpectomy, radiation. Well, midway during my chemotherapy journey, I learned from a cousin on my dad's side of the family that breast cancer is prevalent on the paternal side, and that she was a breast cancer survivor, was diagnosed at 29, and she carried the BRCA1 gene mutation. She recommended that I take a genetic test. So I went to my nurse practitioner. We sat down, we mapped out the family tree and determined that that gene mutation was from my dad's side. The genetic test rather confirmed I carried the BRCA1 gene mutation. So that completely changed the treatment plan that my breast surgeon and oncologist laid out. So after 15 rounds of chemotherapy, I rang the bell, and then I had a bilateral breast mastectomy, breast reconstruction, and a salpingo-oophorectomy, which is a procedure to remove ovaries and fallopian tubes to reduce my risk of ovarian cancer. So I can't stress enough and echo the message from Dr. Elmore and Tiffany and Ashley that it's so important to know your family history. But I'm glad that early detection saved my life, number one, and number two, that I learned about my genetic status and was able to take those preventative measures in a timely manner.
Thank you, Lindsay. And we're going to come back to you. We're going to come back and definitely have additional conversations with Lindsay and Candace. I'm going to now transition to Candace. Candace, will you share with us your journey and how you found out that you had breast cancer?
Good evening. Thank you, Ashley. In February of 2019, during my annual well woman visit, my doctor ordered my very first mammogram. I had just celebrated my 40th birthday. The result of that revealed my diagnosis of ductile carcinoma in situ. And in April of 2019, my surgeons performed an approximate 10-hour bilateral mastectomy with tram flap reconstruction, in which they used tissue from my abdomen to reconstruct my breasts. I was fortunate that early detection saved my life, and I, unlike Lindsay, did not have to undergo radiation or chemotherapy. I was also tested to see if I carried the BRCA2 mutation. And fortunately, I do not carry the mutation, and I have no family history of the disease. every woman's breast cancer journey is different, but for me, the biggest part of my ongoing journey is the constant struggle to gain control of the mental aspects of breast cancer and trying to get my swagger back. So I'm learning to accept this new body, and it's not the same as it was. It's been through a lot emotionally and physically, and I'm still on a journey to rebuild and restore my body and my mind. And as Ashley mentioned earlier in my bio, I created a brand called Survivor Swag. And SWAG stands for Strong Warrior, Always Grateful. The purpose is to inspire others who might be going through something similar. It is a brand. It's a lifestyle to encourage and empower others. Survivor Swag is about healing from the physical, mental, and emotional aspects of trauma. And for me, it was breast cancer, but for someone else, it might be something entirely different. But the bottom line is, no matter what your struggle is or your journey, you're here to tell the story. And so I was fortunate to catch this early. And my goal in life is to be able to bless someone else through my testimony because I survived. And that's where my swag resides.
Thank you, Candace, and thank you, Lindsay. I just want to highlight, I know I've shared a little bit about my journey throughout, but I really want to highlight we have 3 different women here with all 3 different stories. And I think that's very unique because no one's family history is the same. Every woman is unique and different. No breast cancer diagnosis is the same. No family history is the same. No treatment option is the same. And I think that's just so important. All of our paths are different, but I think our goal is the same, and that's to live and to thrive and survive and be here for our families. And I'll share a little more, but I really want to ask Lindsay and Candace both. I think like I said, we all have unique perspectives, but it really helped me to understand how you have approached this information with relatives who might be resistant to getting mammograms or genetic counseling and genetic testing. And let's just have back and forth dialogue. Candace or Lindsay?
Well, I can start. I have a sister who is younger than I am. And as Dr. Elmore mentioned earlier, it's important, because I was diagnosed so early, I have, impressed upon her how important it is for her to start getting mammograms. She's 9 years younger than I am. And so I am constantly, having that conversation with her as well. My daughter, I have a 9-year-old daughter, and I know that she as well will have to start getting mammograms, earlier than she, would have had I not been diagnosed.
I serve as an advocate on the Livingston side to encourage my cousins and aunts to seek genetic testing, to continue to share the information among our family. We gathered for the Livingston family reunion over Labor Day, and I really made an effort to make it known that breast cancer runs in our family. So on my part, I just try to do what I can to continue to share and encourage the women in our family, especially on the paternal side of my family, to know their history and to take the preventative measures if necessary.
That's awesome. I know I'll share a little bit. Candace, I too have daughters, and I wonder daily about, they have a 50% chance of inheriting my mutation. So I wonder daily, I'm not fearful, but I just wonder, what that process is going to look like as they get older. I know in February of 2021, my father underwent genetic counseling and testing since he is a prostate cancer survivor, and having a BRCA mutation makes you at a more increased risk for prostate cancer. And he found out through testing that he does not carry the mutation. So that confirmed that I inherited my mutation from my mother's side of the family. So I think it's so important that we know that We all carry these genes. It's the mutations that can be inherited and passed on both sides of the family. And Dr. Elmore, I want to pass it back to you. Candace said something really important. I heard her say a couple of things. She didn't have a family history. She has a daughter. She knows that her daughter's going to have to be screened earlier. Can you share with us a little bit about the guidelines for women or patients or people who are diagnosed, what those guidelines look like, and as it relates to their children and their grandchildren as it relates to testing?
Yeah, absolutely. And so it's kind of hard to provide a bit of a catch-all because really this is highly individualized, which is why it's really, really important to have that risk assessment with the provider. Because even in the absence of a mutation with a strong family history, we'll often start people screening at age 35 rather than 40. And that may shift based on the age of diagnosis of that affected family member. If someone's got a known genetic mutation, we typically recommend screening starting at age 30. And so there's a little bit of nuance based on the situation that places an individual at higher risk.
Thank you, Dr. Elmore. I'm going to pass it back to Candace and Lindsay. Lindsay, I'll go to you first. I know Candace shared a little bit about Survivor Swag. Lindsay, can you share with us, in your bio, it said that you are the founder of Survive Her. Can you share a little bit more about Survive Her and the work that you are doing in the community and share with the audience?
Yes, Ashley. So Survive Her just celebrated 2 years of existence on October 1st. I'm very excited. When I was diagnosed and I completed treatment and I rang the bell and finished everything, I felt a calling over my life to do something that would be purposeful and impactful in helping women. And really, God said, you need to minister to women and share all of this information that you've learned through the 15 rounds of chemotherapy, through the bilateral, the breast reconstruction, removing ovaries and fallopian tubes, also went through egg fertility and preservation. And so I launched Survive Her to inform, inspire, and to empower women through content collaboration and conversation. And the work that we do is year round. Through content, whether it's through writing an article or conducting a media interview, collaborating with organizations like the Texas Southern University Breast Cancer Screening and Prevention Center or the American Cancer Society, or Ashley with your organization, Pink Legacy 50/50, Candace with your organization, Survivor Swag, and even participating in conversations like this with the Vassar Center for BRCA. And through conversation, keeping the conversation top of mind so that women know it's not just in the month of October that women are diagnosed, but women are affected and impacted by breast cancer year round. We also raise funds to support women who are undergoing treatment who can't pay their bills. We also support women to pay for mammograms, those women who are underserved and uninsured. Part of our messaging is also stressing the importance of genetic testing. So the work that we do is year round, it's purposeful and it's impactful. And for me, Ashley, to answer your question, it's ministry.
Thank you, Lindsay. Thank you. Candace, is there anything that you would like to add about Survivor Swag? And then I'm going to pass it back to Tiffany and Dr. Elmore for a couple of closed out questions.
So I just like to say that, I'm grateful to be able to work with organizations like Survive Her and be an advocate, being a Tiger Lily angel, working with you, Ashley, you and I have done community events, which funds were donated to women who were undergoing treatment. And so it's such a blessing to be a part of this. And, breast cancer has truly offered me an opportunity to make a difference in others' lives. And so I'm very, very grateful for that.
Thank you, Candace. Tiffany, I'm going to pass it to you. Can you kind of walk us through? I know Dr. Elmore gave us those indicators to look for, the rare, young, and multiple cancers. Can you talk with us on how to begin to have those conversations to collect that information from family members? Um, what are some of the best strategies? What are some strategies that we could take away from today? I know Lindsay shared family reunions, but what are some other strategies that you've learned in your profession, or even talking through with some of your patients on how we get started? Like, what are some action items we can do after we walk away from this call to begin to just identify family history?
Sure, Ashley. So one of the really important things to do is just ask questions. I think that most families have someone who kind of collects all the information about individuals' health, and start with those matriarchs or patriarchs, whoever it is in your family, your aunts, your grandparents, um, cousins who are into the genealogy type things, and like knowing about health and learning the ancestry type things. Start with them because they often do keep a record of these things. And it's really important for other family members to know about that as well. I often also want to mention a tool that's important to do that, which is the Surgeon General's tool that can help individuals draw up pedigrees, which are basically a diagram or a picture of family histories going from generation to generation to help you easily identify who's been diagnosed with certain conditions in the family. You can construct those yourself, or you can use a spreadsheet. You can have a book that you keep record of it in, composition book. Some individuals use the Bible, whatever it is that, you can find easily, keep up with, and update easily. Also, sharing this information, it's sometimes a lot easier to do that in a gathering. So, as Lindsay stated, she did it at her family reunion. Some people do it when they get together for family dinners on Sundays, or at different dinners or luncheons that the family may have, just holding a conversation over the phone or a Zoom meeting, talking about it then, at a wedding, when you're at the table with other family members that you may not see that often, and just bringing up the conversation, or sometimes even at funerals. Just whenever you can reach out to those individuals who might have a better idea of what other generations have experienced, and that are willing to share that. I also want to say, don't be discouraged if family members are not willing to share that information. We do know that a lot of families don't like to share their diagnoses, and that's not ideal, but that can be the situation. And because that does happen, that does not need to be a barrier necessarily for you. You can still seek out information from your doctors. You can have that risk assessment done. You don't necessarily have to have a family history to get genetic testing done. And as I mentioned, it's a lot more affordable. And so even if you can't gather that information, there are still avenues to have it done if that's something that you're really interested in knowing, and being able to use that information to guide your health decisions. So we do know that, it's ideal to be able to get that family history. There may be individuals who are adopted who don't know their family history. There are ways to get coverage for testing related to that as well. Even if individuals are not necessarily sharing that information, or you don't know your relatives or your family history, there are other ways that we can help. And it's important to get that support as well. Make sure that you're supported in the decisions that you make. We can make referrals regarding that as well.
Thank you, Tiffany. Dr. Elmore, last question before we go into Q&A. I think in the Black community at some point, we had the saying, what happens in our home stays in this home. What is your response to that as it relates to this topic?
Yeah, that's a great question. As my dad from Alabama used to tell me, closed mouths don't get fed. And so, I think it's really important to, like, sometimes you have to approach something with a little bit of vulnerability. And there's a little bit of education that has to happen on your part. My family has a known genetic mutation that's not, related to breast cancer. And I'm the one that discovered it and had our family get tested. And people were really, really opposed to the idea. And so sometimes you have to realize it may not be the first time that you have this discussion, and that sometimes there's a little bit of heavy lifting, but it's worth it. And so I would say continue to engage your family, approach in a non-confrontational, vulnerable way. And oftentimes you'll slowly kind of break them down, if you will. And ultimately, it can be the difference for your family and for your family's lives for generations to come.
Thank you. Thank you to all of our panelists. And before we pivot to Q&A, was there anything that I did not ask that is very important for tonight's conversation?
I don't think so,
All
Ashley.
right.
You've been stellar.
Well, thank you. So now we're going to transition, to the audience Q&A. Thank you for submitting your questions in advance. If you still have questions, feel free to contact our panelists directly after the program. We will share our social media handles, and you can reach out to us through our social media platforms. All right, so it looks like one question is, and this looks like maybe for Dr. Elmore, what is dense breast, and are there different screening techniques used for screening women with dense breast for breast cancer? Great question.
Yeah, that's an excellent question. And I'll try not to get too technical here, but there are really a few main components to the breast. One is just fat. And the other components are what we call the glandular tissue. So the milk ducts that produce the milk and the ducts that carry that milk out of the nipple. And then there's sort of some connective tissue that's sort of like a suspension for all of that. So the fat is see-through basically on imaging. So women that have very fatty breasts, you can see everything quite well on mammogram. For women that have dense breasts, that means there's less of that fat in the breast and more of that glandular tissue. It actually makes it quite difficult to see through it on mammogram. With 3D mammogram, also known as tomosynthesis, it's a bit better than historically, but oftentimes women will need an adjunct or an alternate form of imaging in order to really be able to get a good window into their breast. So if you have a mammogram that comes back and says extremely dense breast, then you are likely eligible for additional imaging with an MRI, which is basically uses magnets, gets a better window into the breast, is not hindered by density, or in some instances also supplemental ultrasound. So if you have extremely dense breasts, or in many cases heterogeneously dense breasts, it means that you may need additional imaging, and it's worthwhile to talk to your provider about it.
Thank you, Dr. Elmore. Our second question is, if the gene is not present, but your family has a history of breast cancer, should further gene testing still be done with children and siblings? Tiffany, would you like to take that question?
Absolutely. Thank you. So we know that, only about 5 to 10% of individuals that we test will we find a genetic mutation. So the majority of the individuals that we test, we will not find a genetic mutation. And so we like to test individuals who have been diagnosed with cancer, whether it be breast cancer or other types of cancers, because there are other genes that can increase the risk for other types of cancer. And we also know that, BRCA 1 and 2 are just two genes of about 22 genes that we know can increase the risk for breast cancer currently. So we are limited by our knowledge currently of the genes that we know increase the risk for cancer. And we have about 20 to 22,000 genes. Most labs will test anywhere from about 80 to 90, maybe a little bit over that. So there's still a lot that we don't know and understand about how genes affect cancer risk. And so it is quite possible that, or highly possible that we would not find a genetic mutation if we did test, if there is a family history and we tested someone. So in that case, we often still like to monitor other family members who may be at increased risk. And so for breast cancer, for instance, the national guidelines state that we should start 10 years earlier with screening than the individual who was diagnosed at the youngest age. So if an individual is diagnosed at age 40, we recommend screening their children, their sisters, potentially cousins, starting at age 30. And so the issue with that sometimes is getting coverage for screening that early. And so it's really important that talking with your healthcare providers about if there is a gap in insurance coverage, because sometimes their individuals may not yet have established consistent healthcare coverage by that time. And there are typically places that will do mammograms at a lower cost that are still quality mammograms. And it's important to get that information, seek that information out. There are also organizations that will sponsor mammograms at certain times of the year, that kind of thing at a lower cost or for free. So there are some great resources to kind of seek out and look for that. But yes, it's quite possible that we would not find a genetic mutation, but we still like to monitor close family members a bit closer when possible.
Thank you, Tiffany. We're going to take one more question. It looks like, if at all possible, how can I lower my chances of getting breast cancer? I look at that twofold. I look at that as a high-risk woman, my risk management options to reduce my risk of getting breast cancer. But I believe that question was framed for the average woman, or a woman who is who does not know her status of carrying a mutation. So how can a woman or even a man lower their chances of getting breast cancer? Dr. Elmore, would you like to take that question?
Sure. So there's an increasing body of data that suggests that weight has actually been associated with breast cancer risk. And so a big thing that can be done is maintaining a normal weight to help mitigate that breast cancer risk. We also know that minimizing alcohol and smoking can can help decrease the risk of breast cancer. Furthermore, there's actually emerging data now that breastfeeding is associated with the reduced risk of early onset breast cancer, particularly with triple negative breast cancer. So for women that are on the fence and, about breastfeeding, it's important to consider that there can be a protective effect for the woman in addition to the benefits provided to the baby. Unfortunately, a lot of risk factors for breast cancer are non-modifiable, but these are some strategies that can help decrease risk of breast cancer. And you mentioned, Ashley, also women that are at high risk for developing breast cancer. So we talk a little bit about strong family history, but there are some numbers for this. So, if your lifetime risk is greater than 20%, then we consider you high risk. This can be calculated by a provider. There are tools that are created to calculate it, unfortunately, many of which were not validated in Black women. But we know that there are some that are better than others. One called the Tyrer-Cuzick, which is one I routinely use that you could actually Google and calculate your own risk. So if you're in this high risk category, then there could be a discussion with the provider about whether there's a benefit to what we call chemo prevention or medications to reduce your risk of breast cancer by up to 50%.
Thank you. As we close out this Q&A portion, Lindsay, Candace, what is your key takeaway message for us today?
The key messages are to get your annual mammograms. That's number one. And then 1A is if you have a family history, definitely advocate for a mammogram if you're under the age of 40. And then 1B, if you feel something in your breast that's abnormal, like I did, advocate for that mammogram. And number 2, seek genetic testing. Know your status.
Candace?
And my takeaway is request a 3D mammogram. That is what caught my breast cancer early. It was small, but the 3D mammogram is what detected it. Request it if it's not offered.
Thank you. And I guess I'll share my takeaway. And my takeaway would be breast cancer aggressively attacked 3 generations of women in my family, but through genetic testing and counseling, my 3 girls and I can aggressively and preemptively attack breast cancer. So now I want to thank you all for sharing such important, critical information. And to my survivor sisters, we appreciate your transparency and sharing your stories. It was a pleasure serving as your moderator for tonight's informative panel discussion.
My name is Venice Berry, and I do serve the magnificent Missouri City chapter of Alpha Kappa Alpha Sorority Incorporated and its collective of over 700 members as the first vice president. I'd like to thank our speakers, Tiffany Carter and Dr. Alicia Elmore, along with our survivors, Candace Robinson, Ashley Dedman, and Lindsay Livingston. Our committee members, Devonda Hubbard-Peterson, Celia Fitzroy, Constance Mims, and Ashley Knox, and our Houston metropolitan chapters of Alpha Kappa Alpha Sorority Incorporated for joining us this evening. African-American women develop breast cancer at a lower rate than our white counterparts, but we tend to have the worst outcomes. That means we're dying, not surviving. We are our best advocates. Individualized care, inclusive of our family history, self-examinations, lifestyle factors, and cultural sensitivity with collaborative efforts are necessary for African-American women to thrive. So ladies, we are each other's company. We are our best advocates, and we are the best resource for communities to know that we need to survive. Thank you for joining us. You all have a great evening.
And I'd like to just add another important note that Mu Kappa Omega, the Mu Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated and Julia F. Thompson Incorporated will be donating to the Bassler Center for BRCA in support of its efforts to accelerate research at Penn and around the globe. please visit vassar.org/BRCA, /Black BRCA for more information, and stay tuned for a survey from the center that will be forwarded via email. And of course, let's continue this very important conversation about breast health and genetic testing. You can follow all of us and engage on social media. Let's keep this party going, this breast health genetic testing party of importance going. Thank you again for attending, and have a blessed evening, everyone.